Right. Good afternoon, everybody. I'd like to thank Amy Wood and the Raymond Wood Foundation for inviting me to talk today. I think that the treatment of hypothalamic obesity is something that's sort of near and dear to my heart. I've done some research in it and have a lot of patients who have this condition, and hope that this discussion can open up some possibilities for you and just help you think about ways to treat hypothalamic obesity. I have some disclaimers. Why it's not advancing. Sorry, my slide is not advancing. There we go. Sorry. So these are disclaimers that the lawyers at the hospital like me to have, and then these are my personal disclaimers, just to let you know that we will be talking about some off-label use of medications, although some of them are FDA approved for adults and pediatrics, and that I have some research support from a variety of pharmaceutical companies. And please feel free to ask questions either through the WhatsApp room or raising your hand on Zoom, and then we can answer them at the end of the talk. So help make this more interactive and beneficial for everybody. So really today I'd like to discuss the use of GLP-1 analog treatment for hypothalamic obesity, the various GLP-1s that are available in the United States, and then share some of my experience with my patients and ways to get insurance coverage, although there's a giant asterisk for that because I think there are just absolutely no guarantees in terms of what insurance will cover and what they won't cover, and why it seems to be based on the phases of the moon. As you know, hypothalamic obesity occurs due to hypothalamic damage. It can be because of tumor location, tumor therapy, or inherited or genetic conditions, which I won't really be addressing so much today. And especially after craniopharyngiomas, the rate of long-term obesity and rapid weight gain can be as high as 50%. And there are a variety of reasons for this, but I think if you look at, went back too far, sorry. I think if you look at how the hypothalamus and pituitary are controlled together. And I think you've probably heard this from lots of people before, but if you draw sort of an imaginary line between your eyes and another imaginary line above your ears where there's two lines across is where your pituitary gland sits right here. And I like to think of the pituitary gland like the little cell phone that sits in your brain. These different hormones are all text messages that scatter across your body. And then this is the hypothalamus, which is like the integrating network or the LTE network. This yellow line is the pathway of the Rathke's pouch remnant. So if you think about craniopharyngiomas, and they occur along this yellow line pathway, and you can see how they really destroy the pituitary and the hypothalamus. And then when you destroy this network, or this, again, if you go back to thinking of the pituitary sort of like the LTE network, or the pituitary like the cell phone, and then the hypothalamus is the LTE network, then you're losing the ability to integrate all the different signals. And when you lose that ability, or when you damage the hypothalamus, and specifically these neurons that help you with eating behaviors, then you no longer can flip the switch and feel full in the same way. So you have completely different eating behavior. You have completely different energy expenditure because of changes in sympathetic nervous tone. You don't burn calories the same way. You tend to store energy, and because we're not cars, we don't have gas tanks, we can't store energy that way, we tend to gain weight. And it affects sleep and circadian function, again, because of the lack of ability to integrate these functions. You have excess sleepiness and disordered sleep-wake cycling, all of which contribute to rapid weight gain and changes in energy expenditure. So to focus on GLP-1 specifically, this is a protein or incretin type of hormone that's secreted from the intestine in a nutrient-dependent manner, and probably primarily due to intake of sugars and fats. So we know that when you eat a meal that's higher in sugar and fat, you tend to make more GLP-1, and then these other GLP-1 releasing factors that include other hormones you may have heard of, like glucose-dependent insulinotropic peptide, or GIP, which I think when you're reading them sometimes looks a lot like GLP. And then gastrin-releasing peptide, and then some other neuroregulators. It's made primarily in the L cells of the ileum and the colon, and there are GLP-1 receptors throughout the body, specifically in the beta and alpha cells of the pancreas, so then it stimulates insulin synthesis and also decreases glucagon secretion, both of which are really important, not just for blood glucose management, but for other effects throughout the body. It slows gastric emptying directly in the stomach, which helps improve fullness. and also affects receptors in the hypothalamus and the hindbrain that then make you feel more full or improve satiety centrally. We know that there's central actions not just in the hypothalamic regions, and specifically in those regions that are responsible for the regulation of food intake, but there are also receptors in the hindbrain, so that if you have significant hypothalamic damage, we don't think you have those receptors anymore. GLP-1 could still work in other areas of the brain. We know that when GLP-1 is given to both mice and people, that there's a decrease in caloric intake and an increase in satiety or in feelings of fullness. And there are targets throughout the body, so that not just in the brain and on the stomach, but there's effects on, again, slowing gastric emptying, effects on the islets and the pancreas to increase insulin secretion and decrease glucagon. There are peripheral effects that improve insulin sensitivity throughout the liver and the muscle. And at least in adults with type 2 diabetes, we know that there's some improvement in cardiac contractility and cardiovascular effects and such, that there's a lower blood pressure and some improvement in cardiac output. And then, as we discussed, there's an increase in effects in the brain, causing satiety and improved energy expenditure. So it's really because because of the effects on the both brain throughout the body, the sort of ubiquitous presence of GLP-1 throughout the body, that it seems to be an ideal therapy to consider for treatment of hypothalamic obesity. And really, although we have known about GLP-1 for a long time, trying to form a pharmacologic type of GLP-1 has been sort of tricky because it gets degraded so quickly in the body. Dr. Eng, who is an endocrinologist at the Bronx VA in New York, discovered that the venom of the Gila monster contained one of the compounds that was a unique hormone that was very similar to GLP-1, but was resistant to degradation. He named this peptide Exendin-4 and then sold the patent for it to a company called Amylin Pharmaceuticals. And then, unlike most of us who say that we would, quit our day job if we win the lottery, he never quit his day job. He kept working at the Bronx VA actually, which is super cool. But he discovered really the way to keep GLP-1 around from being degraded and to form a pharmaceutical type of GLP-1. So this first one was called exenatide and is still available today, although it's no longer a twice daily shot, but is instead a weekly injection. So there are a wide variety of GLP-1 options approved in the United States. Almost all of them are injectable because they are a protein or a peptide kind of hormone. And so you can see them all listed here alphabetically in the order of all the ones that are approved for the treatment of type 2 diabetes in adults in the United States. I have to say that looking at only the type 2 diabetes studies, the weight loss seen with dulaglutide, lixisenatide, and oral semaglutide does not seem to be as strong as with the other three agents. When we look at what's FDA approved for pediatrics, the options are a little bit more limited in that only exenatide and liraglutide are approved for treatment of type 2 diabetes in pediatrics. They are approved for anybody over the age of 10 as an adjunct to diet and exercise to achieve glycemic control, which is a pretty broad statement, and we'll get to that later because I think that helps sometimes with getting insurance approval. And again, have additional benefits, not only in improving glycemic control in people with type 2 diabetes, but in helping with weight loss. In terms of agents specifically for weight loss, I said before that some of those other agents, lixisenatide and dulaglutide and the oral semaglutide, do not have good weight loss associated with them in adult or in type 2 diabetes studies. I think it's probably due to the size of the molecule, although I don't have good scientific proof of that. Just looking at the different studies, you can see the weight loss is not as good with those agents. And if you have to look at the adult studies, then probably the best weight loss is with high-dose semaglutide and then high-dose liraglutide. Then the weekly agents, both sema and exenatide, are sort of tied, and then daily liraglutide. Although everybody's a little bit different, and I think there's no one size fits all, but looking at the adult data, it would suggest that that's sort of the order of which ones work best. There are two GLP-1 receptor analogs that are approved for weight loss in adults. Those are the high-dose semaglutide, which is marketed as Wegovy, and high-dose liraglutide, which is marketed as Saxenda. The other ones are not specifically approved for weight loss. And then for pediatrics, there's only one medication that's approved for weight loss, and that's high-dose liraglutide or Saxenda. And so we'll start first just looking at high-dose liraglutide and how it has been shown to affect weight loss. You can see that in this study done almost a decade ago, looking at placebo, a medication called orlistat here in the green diamonds, and then different doses of liraglutide in the sort of different shades of purple. You can see medium dose, the blue square is the dose that's approved for type 2 diabetes. This is sort of a medium dose, and this is the high dose that's approved for weight loss. There were 500 patients who started, and you can see they all got intensive diet and lifestyle interventions. And then liraglutide, remember, is increased slowly. So every week you increase the dose to the maximum dose of 3 milligrams. And you can see everybody, as they got on higher and higher doses, sort of pull away as their dose gets higher. Interestingly, at 1 year or 52 weeks, everybody who was on placebo got placed on high dose liraglutide. And so you can see they, instead of having this plateau that they had, started to lose weight. And so there was really a significant weight loss. From randomization until year 1, the patients on liraglutide here, the high dose lost like 5.8 kilograms more than the people on placebo, who lost about 4 kilos. It's really a significant change in weight, and overall lost about somewhere in the 11 kilo or 22 pounds range. And this was sustained over the 2-year study. And it was fairly well tolerated. The most frequent side effects are similar to other GLP1s, which is mostly nausea and vomiting, and they tend to be transient and go away after a few weeks of therapy. There was a great study done looking at GLP1 therapy in teenagers. This was more recent. It was a 56-week study with just 300 teenagers. They were randomized to receive either placebo here or liraglutide in blue. They all got high dose. These were kids aged 12 to 18 who had obesity but did not have type 2 diabetes. 80% completed the study. So again, like a huge proportion made it through the study. Very few people dropped out. And the mean loss was 10 pounds or 4.5 kilos. And that was again sustained throughout the study. Interestingly, though, I think, and we'll get to the slide, is that weight gain increased after discontinuation of therapy in both groups. And again, this is weeks on the x-axis and the change in kilograms from baseline here. So you can see the placebo group sort of maintained and maybe started to gain a little bit towards the end of the study. But then everybody, once the study was over, gained weight. And again, the safety was similar to the safety profile in adults, with about 64%, or a little over half, having GI side effects. 40% had nausea, 34% had vomiting, and 22% had diarrhea, primarily in the first weeks or month of therapy, and then improved. They were slowly increased on dosing and tolerated dose. Only 10% discontinued due to the persistent side effects. Interestingly, and I talk about mental health here, that 10% of the kids on therapy and 14% of the kids in the placebo group had an increase in depression and other mental health issues throughout the study. One patient on liraglutide had pancreatitis that was considered to be very mild and actually recovered without hospitalization or therapy. And one patient in the placebo group had cholecystitis, which is interesting because it's something that's associated with GLP1. They didn't see any cholecystitis or gallbladder disease in the patients on liraglutide, only in one child who was not on liraglutide. There was mild hypoglycemia in both groups, a little bit more in the kids on on liraglutide. So about 26% in the kids on liraglutide and only 14% in the kids on placebo. It was all mild and didn't require any therapy. And I think this is important if you have type 2 diabetes, to remember that you're going to have to adjust your other medications, because it will probably improve blood sugars and cause lower blood sugars if you have type 2 diabetes and start this medication. So liraglutide comes in pens, and the starting dose is 0.6 milligrams. Both the regular or type 2 approved dose of Victoza pen goes up to 1.8 milligrams. Saxenda pen dials all the way up to 3 milligrams. You increase it every week. So you take 0.6 milligrams daily for a week, and then 1.2 daily for a week, and then 1.8. and then 2.4, and then 3 milligrams. It's important to know that both pens do 0.6 milligrams, so you can sometimes do a higher dose with the low dose pen in case you can't get it covered. This is a really lovely young lady who was diagnosed with a craniopharyngioma here at age 5. And this is the height, weight, and BMI curves. You can see age is along here, and then, or on the x-axis up here, and then height and weight and BMI. And just hide this so you can see the whole thing. So here she is at around age 5 diagnosed. At age 6.5, we started growth hormone. She had improved in her growth rate. But here she's starting to gain weight really rapidly, really from time of diagnosis on. There was a brief period of time between age 8 and age 11 when she had really fairly flat weight gain curve. This was due to a combination of intensive diet changes and the use of metformin. But around age 11, she stopped tolerating metformin and was unable to stay on the calorie restricted diet or the carbohydrate restricted diet for a variety of reasons. And then had this again unrelenting weight gain and increase in BMI up to about almost 40. And then at age 15, we started liraglutide and slowly increased the dose. She's only on 1.8, which again is like the type 2 diabetes dose and not the quote unquote approved for weight loss or high dose liraglutide, but it's had this really nice, steady, slow, sustained decrease in BMI, steady, slow, sustained decrease in weight. And we're just going to keep following her. If at some point she plateaus, then we can always increase the dose. So we have a little bit of wiggle room. To circle back to Bydureon or exenatide, as we said before, this was the first GLP1 that was commercially available. It's now available as a weekly formulation, and we don't really use it twice a day. It was really tricky to get something injected twice a day, and you had to have timing of meals as well. There's no dose escalations are needed. It just starts at 2 milligrams, and you take it every week. It is approved in children over 10 and adults for treatment of type 2 diabetes. And this one we have actually studied in kids with hypothalamic obesity. Initially as a pilot study in just 19 patients between the ages of 10 and 20 years. We had 16 patients complete the study. One was lost to follow-up and 2 discontinued due to side effects. This was again on twice daily exenatide and was a 6-month study where everybody received product. You can see overall that it was really weight neutral in all of the patients. Although if you look at the rate of weight gain prior to being in the study and the rate of weight, like sustained weight or weight loss during the study, there was a significant improvement in BMI, or a significant treatment effect, I guess you could say, even though there wasn't an absolute change in BMI, or we could consider it to be like a weight neutral study. But because of this pilot study, we then went on to have a bigger study looking at the use of exenatide in patients with hypothalamic obesity. This was a 3-center study looking at 42 patients aged 10 to 25. They were randomized to receive either weekly exenatide or weekly placebo, and then had 18 weeks of open label where everybody got the exenatide. Again, a change in BMI wasn't statistically significant, although you can see here that some patients really dramatically improved both in the first 18 weeks or when they were on it, and then in the open label period, we compared the kids who were on GLP1 and the randomized, because the open label was only 18 weeks, just compared 18 weeks to 18 weeks. There were some patients who did dramatically improve, and overall, everybody had a lower body fat, which I also think, like in the prior study, is really clinically significant, if not statistically significant. When we look at the kids and compare the kids on exenatide, the weekly exenatide throughout the study and on placebo, you can see that more patients on weekly exenatide than patients on placebo actually lost weight, although a similar percentage gained weight. And then there was a good percentage that just maintained, which again is, I think, in hypothalamic obesity, a clinical victory. Then I have 2 patients I wanted to share with you. One of them is a girl who was diagnosed with a craniopharyngioma at age 6.5, had a year before we started growth hormone, and then here again was going well. She did have a recurrence and got radiation therapy. She had this steady weight gain really from time of diagnosis, with a relatively slower increase in BMI, but nonetheless really significant increase in BMI. At age 16 and a half, almost 17, she started on the weekly exenatide and lost weight on the study. She elected to stay on exenatide and came back about a year later to see me. She doesn't live in Minnesota or in my state, but is still losing weight on product, which looks really great and is exciting to see. And then this is a young man who was diagnosed with a craniopharyngioma shortly before his 10th birthday. After 6 months, he was started on growth hormone, and you can see his increase in growth rate. His weight gain started from the time of diagnosis throughout the first year, at which point he was actually on twice daily exenatide as part of our pilot study. And then here remained on twice daily exenatide, and at age 12 switched to the weekly form of exenatide. Has maintained a really an amazing BMI, or body mass index, really between the 50th and 75th percentile for several years, taking weekly exenatide. And because he's doing so well, he says he doesn't want to go on anything else. He feels like this is like the right thing for him. He's quite articulate. I think I'd be remiss to not address semaglutide, although I have a hard time getting it covered for my patients. I think primarily because I see mostly pediatrics, and it's really not approved for peds, either for type 2 diabetes or for weight loss. But it does seem to have the best weight loss overall. It, like liraglutide, comes in a very easy to use pen, and you dial starting at 0.25 milligrams weekly. Every month you increase the dose to a target dose of 1 milligram for type 2 diabetes, and to 2.4 milligrams, which is marketed as Wegovy. The type 2 diabetes dose is marketed as Ozempic in the United States. This was an amazing study that was completed last year and published earlier this year, looking at about 2,000 adults with obesity over 68 weeks who were given high dose semaglutide. So again, the dose was dialed up from, you can see, like every month, right? So 0.5, 1, sorry, 0.25, 0.5, 1 milligram, 1.7, 2.4 milligrams. So by 20 weeks, we're on high dose semaglutide. And they were 2/3 on medication and 1/3 on placebo. Most of them were women and most were Caucasian. And I think that's pretty common in most weight loss studies. And again, probably for a variety of reasons, and hopefully that will change. But the amazing thing is that they had this like dramatic and sustained weight loss over the course of the entire study of 16, you can see change from baseline is 16%. And so you think if like a person is about 250 pounds, that's 40 pounds, 16% is a lot of weight loss. And it's approaching the weight loss seen with bariatric surgery. The common side effects, I think you've seen from these different studies, really are nausea, diarrhea, and vomiting, which happen in about half. So, somewhere around 50 to 60% of people on it. It tends to be self-limiting. It gets better with time, and it's better when you slowly escalate the dose. Although interestingly, it's not worse with exenatide, which has no dose escalation. I think because the medication does cause slowing of gastric emptying, you have to be careful if you have gastroparesis or if you already have slower gastric emptying. You also have to be careful if you have really bad reflux. Those people in my practice anyway tend to have more nausea and more emesis or vomiting from the medication. I put a question mark by pancreatitis because there's still a black box warning regarding pancreatitis, and prescribing information for physicians says that you need to be careful if people have pancreatitis. But when we look at all the type 2 studies and compare like people who get pancreatitis who have type 2 diabetes to people who get pancreatitis who have type 2 diabetes and are on a GLP1, which again is maybe not the same population as hypothalamic obesity, but still a population we can look at, there's no increase. So I think the association between GLP1s and pancreatitis is maybe not as strong as we thought it was when we first started using these agents. There is an increase in gallbladder inflammation and stones. Again, in the teen study, it was only found in the child who wasn't on GLP1, but it's still something that we look for and are concerned about, especially with prolonged abdominal discomfort or abdominal pain. And then lower blood sugar levels happen frequently, especially if you already have type 2 diabetes. You may need to change your other medications. There is a black box warning not only regarding the pancreatitis, but also regarding something called medullary thyroid carcinoma. So in mice studies of GLP1, there was an increase in a very specific type of thyroid cancer called C-cell tumors. There's been no human cases of C-cell tumors in people on GLP1. Humans get this type of tumor. But I think it's also because humans have a different type of GLP1 receptor expression in our thyroid C cells. So we're a little bit different than mice. And I think that gives us a little bit lower risk on these medications. But nonetheless, there is a warning. It is contraindicated if you have a family history of medullary thyroid carcinoma, which is a very specific type of thyroid carcinoma, or if you have a very specific underlying condition called MEN2 or multiple endocrine neoplasia type 2. In my practice, I think I always step back and like remember what ones are FDA approved, so that although Saxenda is approved for weight loss in both adults and children over the age of 12, insurance companies are just like sort of tricky and not really keen on paying for medications for obesity, but they are very keen on paying for medications for type 2 diabetes treatment. And so I find that because they're approved for the treatment of type 2 diabetes in patients over 10 years of age, especially if they've failed an oral agent, that sometimes if some of the patients have gone on metformin or any other agent that could be considered an oral agent for the treatment of type 2 diabetes, that's an important piece of information to share with your insurance company, and will often allow for approval of exenatide or liraglutide, since they are both approved for treatment of type 2 diabetes in kids over the age of 10. Insurance companies are getting more savvy and starting to ask more about whether they actually have the diagnosis of type 2 diabetes. So this may not always work, but does sometimes provide a little bit of a loophole. There are copay assistance available from all of the pharmaceutical companies. Again, I just kind of listed them in alphabetical order, and you can find the information on their websites or through their kind of funnily marketed 1-800 numbers. And have had pretty good luck with some of our patients if they get some coverage to get their copays down to $25 or less per month. The options then again to like kind of go over depending on your insurance coverage, and then just to discuss like some issues with the pens themselves and what some of my patients find with the pen. So semaglutide comes in a really nice, easy to dose pen, very similar to insulin pens. However, each dose requires a different pen. So the 0.25 and 0.5 milligram doses can come in one pen, which only dials to 0.25 or 0.5. It doesn't dial to anything higher than that. Then there's a 1 milligram pen that only doses at 1 milligram, a 1.7 milligram pen, and a 2.4 milligram pen. If you have the 0.25, 0.5 pen, which is easier to get approved, you can escalate. And the way to do that is to, put the needle on the pen, start giving your injection. Don't take the pen out and then dial to 0.5 again, administer 0.5, dial to 0.5, administer 0.5. So you can escalate to 1.5 or 2 with a lower dose pen. You just can't get to 2.4. And I've been reluctant to advise anybody to go to 2.5, although maybe it's not significantly different. It just makes me a little nervous. Exenatide comes as a single pen that does 2 milligrams. There's no dose escalation. It's never been tested in higher doses. You do need to mix the medication in the pen. So you have to dial the pen together to mix the powder and the liquid together, and then you need to shake it for a good 4 to 5 minutes. It is hard to get in suspension, but once you get it there, it's really nice. The needle's a teeny bit larger, which some people get a little nervous about, but it's still a subcutaneous or injection that goes in your fat cells, so it isn't super painful. Liraglutide pen is very similar to the semaglutide pen, so it's already pre-mixed, and you just put the small 32 gauge or small pen needle on the end of it. The Victoza pen will dose up to 1.8, and the Saxenda pen will dose all the way to the 3 milligram or higher dose. Both pens adjust at 0.6 milligram increments, which is kind of awesome. And that means you can give higher doses with the lower dose or with the Victoza pen. And it's fairly easy to crank your dose up to 3 milligrams with the lower dose pen. You just need to get more pens approved, which is sometimes easier to get through insurance than getting Saxenda approved. Again, for goofy reasons that I can't explain, I can just share. And overall, when I work with my kids and my patients, is to start low and increase slowly, and to not get frustrated if you have to titrate more slowly. Most of the kids tell me that they just feel uncomfortably full. And I think, as Marcy Sirota discussed earlier, sometimes people with hypothalamic obesity tend to be really carbohydrate sensitive. And being on a GLP-1 sort of aggravates this. And so if you have a really large carbohydrate meal or a really large fat meal, it makes you feel even more uncomfortably full. And that can translate into sometimes nausea as well, or vomiting. And people will get diarrhea occasionally on the medication. And if they have too many side effects, you just dial the dose down and sort of increase again more slowly. But everybody who responds to the medication, which is probably about 30 or 40%, note a decrease in appetite and then decrease in snacking. They just don't feel full. They don't feel hungry between meals, and they're full with smaller meals. But remember, not everybody is the same. You have to find your ideal or highest tolerated dose and consider an increase months later if you need to, or never an increase if you're doing well on low doses. There's no one right answer. Insurance preference is really not even occasionally, but it's really an issue. And since some pens are dose specific, sometimes that means doing, kind of a tricky 2-dose to escalate your dose. And you may need a